My name is Axel Groth. I'm a medical oncologist at Mayo Clinic in Phoenix, Arizona. I'm here to discuss, as part of a roundtable discussion, optimization of late-line therapies in metastatic colorectal cancer. With me are Dr. Bekaii-Saab from the Mayo Clinic in Phoenix, Arizona, and Dr. Eric van Cutsem, providing a European perspective from Belgium Leuven. Yeah.
Thank you.
Great to have you here. So we'll talk about late-line therapies or the later-line therapies in metastatic colorectal cancer. This also ties into some new developments I've seen at ASCO GI again, the so-called reverse study, which I'll ask Tony about, and then we'll also like to talk about, to finish up the idea of later-line therapy, immunotherapies, we need to talk about this, and HER2-targeted therapy. I think these are very important topics. But let's Tony, I'll throw the ball at you. The Concur study, which Eric mentioned before, in less heavily pretreated Asian patients, seemed to have a larger survival benefit than the correct study. So what about other data moving regorafenib earlier in the lines of therapies? And what do you think about the data that were recently presented?
Yeah, so that's very interesting. So as you said, Concur does concur with correct that there's a survival benefit, but the hazard ratio, both for PFS and OS, seem to be more interesting, and that's patients were less pre-exposed to the biologics. So reverse was a study from Japan, large phase 2 randomized study that essentially looked at moving regorafenib ahead of cetuximab versus the reverse, meaning cetuximab followed by regorafenib. So that study overall was positive for its primary endpoint, which suggested essentially regorafenib followed by cetuximab strategy improved survival over cetuximab first, followed by regorafenib, which essentially goes with the spirit of Concur, meaning trying to move regorafenib earlier in the biologic scheme seems, for some reason, to improve overall outcome versus the reverse. And this effect seemed to be primarily driven by moving regorafenib, not by moving cetuximab one way or the other. Cetuximab kept its value, whether you give it first or later, but regorafenib seems to have gained value when you give it first rather than later. Now, granted, this is, again, a phase 2 randomized study. It's also in Japanese population, patient population. And I think it's important. It's an important study because now this is the second study that suggests moving regorafenib perhaps to earlier lines, a little bit earlier. I wouldn't say earlier lines, but a little bit earlier may actually improve outcome for patients, and certainly needs to be validated further, either in Western patient population or in a more global study.
Yeah. So, just to highlight, the difference in survival was 6 months.
It was
something
6 months.
We cannot completely ignore. That is a big difference in this later line setting.
Yeah.
That's the median survival of patients, of untreated patients in this setting.
It was pretty impressive.
So whether or not we'll ever be able to see a validation study remains to be seen. Is this the right time? Because, of course, there are more interesting topics. People jump on immunotherapies all the time. There's almost, whenever you have the label of immunotherapy in a trial, in a later line setting, however, attractive this might be for us, patients love it. And so, Eric, where are we with immunotherapies in later line setting? And I want you to highlight to break it down by MSI high and MSS patients.
Yeah, what we do know today is that clearly patients with an MSI tumor, and around 4 to 5% of patients with metastatic colorectal cancer have an MSI, microsatellite unstable tumor, they clearly benefit from a checkpoint inhibitor. We have data from pembrolizumab studies, we have data from nivolumab studies, and recently also we have the data from the nivolumab plus ipilimumab studies. They all show that there is a clear benefit for the checkpoint inhibitor in MSI patients. And that's standard, that's approved in the US. That's, however, not yet approved by EMA, although we think scientifically that that's the best option for these patients. What's
holding it up in Europe? What's going on?
Well, there is a discussion with EMA, and these studies are not randomized. And that's probably one of the discussion topics at EMA, that they need and want to have a bit larger data sets. Personally, I do think that that's not a correct approach. If you see that I've treated a lot of patients in clinical setting. If you analyze the data from the different published clinical trials, it's clear that these drugs are active in these patients.
And it's an unmet need. I mean,
and it's a clearly unmet need. It's a better treatment option for these patients. That's for sure true.
Tony, what about MSS tumors?
Yeah, so unlike the microsatellite unstable or MSI high tumors, the microsatellite stable tend to be less hypermutated. In fact, some of them have a low tumor mutational burden, so they're less likely or unlikely to respond to immune therapies. So strategies to try to turn these so-called cold tumors into more hot tumors, invite those tumor-infiltrating lymphocytes into the milieu, may theoretically at least enhance the likelihood of these PD-1 inhibitors like pembrolizumab and nivolumab to have their effect. Preclinically, there are a number of strategies that have proven to be useful. The MEK inhibitors overall, although primarily a non-specific immunomodulatory agents, I mean, these agents essentially seem to inflame the tumor, make it more visible to immune cells, to T cells, and then when combined with PD-1, PD-L1 inhibitors seem to essentially have activity similar to what you see with the MSI. Similar, not the same. There are other strategies as well that are being developed that seem to make sense as well. And some of them are a little bit more specific in terms of activating T cells. And these are also being developed. But the one right now that's most advanced is the MEK inhibitor plus PD-L1, specifically cobimetinib and atezolizumab. The study was started as a phase 1b study. The first report on this looked somewhat promising. There was an update at ASCO GI for the phase 1b that still places the response rate a little bit around 8%, 8 to 10%. Not as impressive as the initial data, but you still see some responses and some solid responses. The phase 3 study completed, and it was a study that looked at cobimetinib plus atezolizumab versus atezolizumab as a single agent versus regorafenib as the comparator arm with the hope to improve survival. So we'll have a little bit more data on that group of patients, should be somewhere in the summer. But overall, the strategy of trying to bring these immune therapies into microsatellite stable tumor is a very hot item. The preclinical data suggests that we can do it. Whether MEK inhibitor is the optimal way to do it or not, and if that study is positive, great, it creates a new standard. If it's negative, I still think that it would continue to be worthwhile to explore other strategies in this space because we can do it.
And it will likely not necessarily be positive for all patients. You know, from the data we've seen, there's probably a subgroup of patients.
There's a signature.
We try to look at, who are these patients who can be, where the immune system can be activated. So last topic I want to talk about briefly, HER2 positive cancer. So Eric, we've seen data from my pathway study, from the Italian study, the Heracles study. And other studies are ongoing right now. There's a randomized study in the United States, an intergroup study. So do you test for HER2 amplification in your clinical practice?
Yes, we do test systematically in these patients for HER2 testing, especially the patients with a RAS wild-type tumor, left-sided, because they have a higher chance of being HER2 amplified. And it's around 3 to 5% of the patients who are HER2 amplified. So in the chemorefractory patients who went through the different treatment options, cytotoxics, and through bevacizumab and the EGFR antibody, we test systematically for MSI and for HER2. And if patients are HER2 amplified, then we propose them a treatment, preferably in a trial, but if there is no trial possible, we try to solve it also with the combination of trastuzumab plus lapatinib. It is shown that the combination is probably the better option. The Italians who did that xenografts and later on the first clinical study have shown that. This combination, according to the initial experience, reported in around 1 out of 3 of the patients an objective response. So this is again an unmet need population where we test and where we treat these patients.
And I think the intriguing part here is you have a biomarker for positive selection, and you see the responses without chemotherapy. You target biology, and I think this is critical.
Yep.
Okay, very well. I mean, so we have options, and there's actually already outlined future options. So in this roundtable discussion, I think we explored real efforts to optimize later-line therapies using existing agents that we have available and from a regulatory perspective, Task 102, and in particular, with the dosing strategies that Tony described with the readout data with regard to regorafenib, which I think toxicity management was an unmet need, is an unmet need. So I think we will hopefully see how this gets embedded into clinical practice. And new data, immunotherapies, the holy grail of treatments making MSS tumors immunogenic, and then subgroups of patients like HER2-positive cancers. And hopefully we'll see a kind of a slicing down of further subgroups that will be amenable for targeted interventions. Thank you for listening. Hope it was interesting for you and for your clinical practice.